biotoxin.
Me, at a time to list Dr. Johnson's point that you don't have problems because it's not physically present. Borrelia, Cincillado, so maybe multiple.
The most important thing, if you want to do this work, is get certified.
I think the big message I want to get across with this call is this is a complex thing.
Well, good morning again. So the slides up here. So what I'm doing is presenting the medical part of the diagnostic module consensus report.
Could you speak up a little
I
bit?
have no disclosures to make, and Michael's disclosures are listed here. So this consensus report was published in the Internal Medicine Review in just beginning of this month, in 5/18. It was approved by the research committee, has been approved by the entire surviving listserv, and it's a guide to diagnosing SIRS, is the whole point of the report. And I will be discussing the diagnosis of SIRS from a medical perspective, and I will be followed by Michael Schranz, an environmental professional who will be discussing the fundamentals of a water-damaged building. It is the first multidisciplinary consensus to look at SIRS, water-damaged buildings, post-Lyme, ciguatera, and cyanobacteria. It's also the first to look at water-damaged buildings and human health as a landscape, and includes the medical evaluation, an independent environmental professional assessment, symptoms associated with SIRS, lab abnormalities associated with SIRS, and lastly, transcriptomics. There has been rapid expansion of data. Transcriptomics and the development of additional ancillary testing has provided greater understanding of SIRS, along with improved diagnostic precision. And as clinicians, we need to keep up with the research to offer our patients the best outcomes. What is chronic inflammatory response syndrome, or commonly called SIRS? It's defined as a multi-system, multi-symptom illness acquired following exposure to environmentally produced toxins. There must also be laboratory testing results similar to those seen in peer-reviewed published studies, and there must be documentation of response to therapy. SIRS affects the immune system with prolonged activation of the innate immune response. There's also upregulation of inflammation with persistence of inflammatory cytokines. There's impaired regulation of hormonal function, including neuropeptides, and abnormalities in adrenal and sex hormones. It's associated with altered capillary perfusion and coagulation system defects. SIRS has evolved since it was first described several decades ago. The case definition evolved from dinoflagellate illnesses, Pfiesteria, Miss Pfiesteria there, and ciguatera in the late 1990s, and then later from exposure to cyanobacteria in 1997, and then went on to include exposure to microbes from the interior of water-damaged buildings in 1998. And the basis to explain the underlying mechanism resulting from these different sources of exposure was provided by the similarity of symptom groups and the commonality of inflammatory abnormalities, then with the addition of visual contrast sensitivity, testing abnormalities, and HLA-DR typing by polymerase chain reaction. And then with the identification of biotoxin produced by Borrelia burgdorferi, or Lyme, in 1998, cholestyramine was used, given its benefit in other biotoxin-related illnesses. However, this resulted in a marked adverse reaction in those patients that had Lyme, and we labeled it intensification, and was shown to be due to a massive pro-inflammatory cytokine response with marked elevation of matrix metalloproteinase 9, or MMP9. This challenge then provided a source for further therapies on the protocol. So how do we diagnose SIRS? First role of the clinician is a detailed review of past medical records. We cannot rely on patients' recall, self-based diagnosis, or previous meaningless diagnostic labels such as chronic fatigue, fibromyalgia, irritable bowel syndrome, or other diagnoses. We have to document potential for exposure to an environmentally produced biotoxin. This can be from a water-damaged building, Borrelia toxin, toxic spider venom, ciguatoxin, or cyanobacteria. Infectious diseases will often set off inflammation that persists well beyond the clearance of the infectious disease. Assessing exposure from a water-damaged building will be discussed following this talk by me, and an in-depth discussion of SIRS post-Lyme, ciguatoxin, and cyanobacteria will be presented, I believe, on Sunday. Cluster analysis is part of diagnosing SIRS. It consists of 37 symptoms of SIRS, which are divided into 13 different clusters. In an adult, presence of 8 or more of the 13 clusters, or in a child, presence of 6 or more of those 13 clusters, is 95% diagnostic for an unspecified type of SIRS. And this provides the ability then to take subjective symptoms, pass them through a skilled medical history, and then categorize them in the cluster analysis. If multi-symptom illness is not identified, the person does not have SIRS. The case definition also includes lab abnormalities, and we see a reduction in regulatory neuropeptides, elevation of at least 1 of 3 inflammatory markers. There's dysregulation of ADH and osmolality, dysregulation of ACTH and cortisol. Abnormalities are also seen with the presence of autoantibodies and VEGF, or vascular endothelial growth factor. There must be the absence of confounding exposures or other diagnoses, and the differential diagnosis ends when there's near 100% exclusion of all other possible causes of illness, or with resolution of visual contrast sensitivity testing abnormalities, lab, nasal culture, and transcriptomic abnormalities. As SIRS has evolved, so have a lot of myths surrounding SIRS. And the list there lists some of the SIRS myths that have come to circulate, and I want to put some of these myths to rest, as none of the following are true. Fungi in the nose are pathogen and must be treated. This has created a lot of problems, especially with development of resistant Marcons. I think we can inhale a lot of mold spores that can get picked up on a routine nasal culture. It does not mean that you've got a fungal nasal infection. Urine mycotoxin testing is a useful tool to diagnose SIRS. I think if this was ever useful, it's outlived its utility, and it really doesn't reflect in any way what's going on with the innate immune system, which is really what we're looking at with SIRS. Eating food containing mold should be avoided, as this can aggravate SIRS. I think it can result in mycotoxins showing up in the urine. And I think a lot of our food has mold on it, we just don't see it. So, avoiding something that looks obviously moldy, I think is a good idea generally. New construction and no visible mold in a building are safe to inhabit. I've seen, I think the environmental professionals will discuss that in more detail, but I've had a number of patients who thought that that was going to be their solution, and either materials were green or the building got rained on before it was enclosed, and microbial growth ensued as a result of that. Arid climates are safer than humid climates, although living in Hawaii certainly has made me facilitate or understand how mold growth occurs. I was amused to see the little sign in the bathroom, turn your towels green. In Hawaii, that happens all the time if I don't put them in a towel warmer. I don't think that's quite what they meant in the hotel room here. Mold testing methods done with settle plates, spore trapping, and tape lifts is all that's necessary to rule out or rule in mold. And I think that's going to be discussed in more detail by the environmental professionals at another talk. History taking, very important in diagnosing SIRS. We need to record treatments that have been tried and medications and supplements taken. We want to know what's worked, what hasn't worked. Specifically question whether antifungals have been used. We need to ask about dental health. We need to look for a history of root canals, implants, which can result in cavitations that can contribute to ongoing inflammation. We want to ask about exposure to other toxins. We are exposed to a lot of toxins, and that can contribute to our overall inflammation and lack of optimal health. An in-depth review of the cluster analysis questions is important, to go over that specifically with the patient and not have the patient complete a tick sheet prior to us seeing the patient. And those results need to be recorded in the history, along with recording a review of systems, past history, family history, and social history. We want to take an environmental history. It should include the location and type of exposure. Was it inhalation or contact? The mechanism of exposure, and frequently the duration of exposure is less important than the intensity. Exposure questions include exposure to interior of water-damaged building. Was there a tick bite that preceded the onset of the illness? Was there a brown recluse or black widow spider bite? Was the illness preceded by eating fish, or exposure to a body of fresh water, exposure to an ocean algal bloom, exposure to an estuary fish kill, or closed shellfish pit? And exposure for a non-HLA susceptible patient markedly reduces susceptibility for SIRS, but doesn't completely eliminate it. Cluster analysis is a very important history tool for diagnosing SIRS. And symptom clarification is extremely important to be certain symptoms are present on a day-to-day basis and not something that occurred 6 months ago or occur infrequently. There are unique symptoms associated with SIRS that are often confounding or confusing at best to practitioners not familiar with diagnosing SIRS. And they can include unusual pains that are sharp, stabbing, come unexpectedly, and reappear elsewhere in the body the next day. They can be ice pick in nature. People can have involuntary muscle spasms that result in unusual posturing of the fingers or toes, described as clawing. Severe cramps can occur in the middle of the night when people stretch out their feet. Aching, or what's known as enthesopathies from capillary hypoperfusion, at the musculotendinous junction can be seen. Joint stiffness after cessation of activity, described as a gelling, is seen with SIRS. Sudden weight gain from leptin resistance. Dyspnea, cough, sinus congestion. Push crash is something unique to SIRS, and I think a lot of people with this may get diagnosed with fibromyalgia or chronic fatigue syndrome. And this results from overdoing it when feeling better. And overdoing it is probably just doing what a normal person would do. But the person feels better and they want to get on with living their life. And then this is followed by several bad days that results from impaired glycolysis due to abnormalities in ribosomal and mitochondrial genes, which create a tight reduction in available energy supply. And this has been described with the work done with transcriptomics. Abdominal pain is abdominal pain, bile acid reflux, delayed gastric emptying can be symptoms of SIRS. Important to evaluate patients that have a history or a diagnosis of IBS or SIBO more carefully. I find that a lot of my patients with SIBO really never ever recover or frequently relapse unless SIRS is addressed. So it's a very important diagnosis to look at. Headaches that can last longer than 24 hours. And this is seen with the dysregulation of ADH and osmolality. Hypermobility can be seen, especially with certain HLA types. There's unexplained fatigue, unusual skin sensations. A lot of patients, especially women, can't stand rough clothing, tight clothing, have to take all the tags out of the back of their shirt because they can't stand it touching their skin. I also have complaints, a lot of women with hair loss, and in my research on this, I think TGF-beta elevation is one abnormality associated with increased hair loss. There's neuropeptide abnormalities that include excess sweating, sleep disturbance, temperature dysregulation, frequent static shocks, appetite, and mood swings. There can be eye symptoms consisting of blurred vision, red eyes, light sensitivity, tearing, and cognitive complaints. This is frequent for a lot of my patients. They come in with what they describe as brain fog, impaired concentration, confusion, memory issues, difficulty with word recollection, and toxins are type 3 on the Bredesen protocol. And I frequently diagnose SIRS in my Bredesen protocol patients, making this a very important diagnosis to rule out and treat if present to prevent further cognitive decline and hopefully reverse some of it. Sorry, I think I should advance my slide. Physical exam.
So, type 3, you're referring to dementia, new dementia description as type 3 in the Bredesen protocol?
Correct. Type 3 is the toxin.
Toxin related?
Yes, toxin
dementia.
related is type 3. Physical exam. Obviously, we need to take good vital signs, measuring blood pressure with the cuff and not with a electronic wrist device. We need to take their temperature, their pulse oximetry, and respirations, with special attention paid to the quality of respiration. Head, ears, eyes, nose, and throat exam with attention specifically to erythema of the cheeks, or what's been described as mold facies. There can be scleral injection, acne, nasal polyps, turbinate enlargement, gingivitis, thyroid abnormalities, cranial nerve dysfunction. Often cranial nerve 7 or the facial nerve weakness can be seen. Also look for lymphadenopathy. Careful pulmonary exam, listening for wheezes, rhonchi, ralls. Cardiovascular exam, listening for S1 with wide splitting versus a gallop. Increased predisposition for aortic abnormalities are seen in patients with a disproportionately long wingspan compared to their height. And this is seen with HLA 11352B. And TGF-beta also can cause aortic abnormalities. And so it's also important to evaluate for signs of right heart failure, edema. Abdominal exam, I don't think there's anything specific here for SIRS, but obviously it needs to be done and document any abnormalities. Extremity exam, you're looking for arthritis, for temperature, capillary refill, proximal and distal weakness. Is the shoulder shrug against resistance equal right and left? Is the wingspan greater than the height? Neurological exam, we here focus on abnormalities and distribution and sensation of light touch, vibration, monofilament testing, pinprick sensation. Mental status, as I mentioned, this is type 3. We look also specifically, there's appears to be a selective dropout of math function with SIRS. Integument, dermatographia is seen especially with increased levels of C4A, and then the hair loss that I mentioned.
One quick question. Is there any selective loss of remembering names? Is that one has been studied?
It can be.
That's more often I'm hearing from my patients also, than that.
Yeah, it's remembering names or words are frequent complaints with brain fog, when they come in complaining of brain fog and memory, yes. So in addition to the history, the cluster analysis, the physical exam, there's a lot of ancillary testing that's done as part of diagnosis with SIRS. Visual contrast sensitivity testing, or VCS, is a test of neurological function of vision. And it's the ability to see graded change of contrast. VCS testing identifies contrast vision loss from a variety of environmental sources of illness in a non-specific manner. So it doesn't tell us what's the cause, it just tells us there's a problem. It can be done online or preferably by a handheld test in the physician's office. A pass is the ability to see row 7 or greater in column C and row 6 or greater in column D. When VCS is failed, and we combine this with a positive cluster analysis, the accuracy of diagnosis of SIRS is 98.5%. So a pretty significant diagnostic ability or accuracy. Pulmonary artery pressure is another ancillary test, and it's calculated indirectly from the tricuspid jet velocity on an echocardiogram. A stress echo can also be done to evaluate pulmonary artery pressure change with exercise, and any rise over 8 millimeters mercury is abnormal, and this increases the indication for VIP nasal spray use. And acquired pulmonary hypertension is found in over 75% of SIRS patients. VO2 max and anaerobic threshold measured by cardiopulmonary exercise testing is an important test to classify possible disability related to SIRS. Push crash, as I previously discussed, is frequently associated with reduced anaerobic threshold. Neuroplant cranial MRI. This is a volumetric measurement of the brain, and it can identify and separate abnormalities from SIRS water-damaged buildings, SIRS post-Lyme, ciguatera, traumatic brain injury, PTSD, and multinuclear atrophy. SIRS water-damaged building has specific findings showing enlargement of the forebrain parenchyma, cortical gray hippocampus and globus pallidum, and decreased volume of the caudate nucleus with normal thalamus and putamen. SIRS Lyme, in contrast, shows different changes with decreased volume of the putamen and forebrain parenchyma with enlargement of the thalamus and cerebellum. Cortical gray, hippocampus, and caudate nucleus are normal in Sears line. And the neuroquant can make the differential diagnosis easier as other illnesses do not have similar findings, hence the utility of doing this test. And correction of multinuclear atrophy after SIRS treatment protocol is also seen when neuroquant MRI is repeated after treatment. Proteomics. This is another ancillary test, and it is laboratory testing done to identify upregulation of the innate immune system. And it looks at multi-system dysfunction, it looks at genetic susceptibility, it looks at neuroregulatory peptides with a deficiency frequently seen as a result of biotoxins binding to cell surface receptors. And then this leads to an upregulation of inflammatory pathways, resulting in an abnormal rise in inflammatory markers such as cytokines, TGF-beta1, complement split products. Cytokine effects result from abnormalities in MMP9, leptin, MSH, and this can result in coagulopathies and hypoperfusion. And proteomics also looks at T regulatory cell deficiency. Some of the proteomic markers I will discuss. And first one is MSH, which is a crucial neuroregulatory peptide. It regulates the immune system. It controls inflammatory signaling molecules by inhibiting NF-kappa B, TNF-alpha, IL-1 beta, and IL-6. These abnormalities result in a multitude of symptoms, including myalgias, temperature instability, headaches, decreased concentration. MSH also controls tight junctions in the gut, an overlooked cause of leaky gut. This further increases the risk of autoimmunity that already is seen with SIRS as a result of the leaky gut. Low MSH also causes sleep disruption and results in loss of cortisol regulation with lack of cortisol ACTH feedback. Correction of MSH is also mandatory to correct androgen and estrogen imbalance. Vascular endothelial growth factor, or VEGF, and transforming growth factor beta, or TGF-beta, are both proteomic markers. VEGF is often reduced and TGF-beta is frequently elevated. Elevated TGF-beta and reduced or VEGF deficiency both contribute to increased blood-brain barrier permeability. VEGF is initially elevated as a result of tissue hypoperfusion. However, elevated TGF-beta, we believe, is the cause of subsequent reduction of VEGF levels. VEGF deficiency then results in further capillary hypoperfusion, causing dyspnea, cognitive dysfunction, fatigue, and muscle cramps. TGF-beta is the conductor of our immune system, maintaining balance between the pathogenic T cells and T regulatory cells. Elevation of TGF-beta promotes stiffening of epithelial cells, resulting in what's called epithelial mesenchymal transformation. And when this occurs in the lung, fibrosis occurs, resulting in a restrictive airway pattern. Immune dysfunction is seen with SIRS. Immune system defects lead to abnormal T cell responses and a dysregulated complement cascade. Inhalation of particulates from water-damaged buildings induce conversion of CD4, CD25 T regulatory cells into pathogenic Tregs. CD4 and CD25 normally suppress autoimmunity. However, once they become pathogenic T cells, they're able to induce autoimmunity and add to further tissue inflammation. SIRS patients can develop autoantibodies as a result of this, with development of anticardiolipin antibodies, anti-gliadin antibodies, with associated gluten intolerance, anti-neutrophil cytoplasmic antibodies, and more. Derangements are seen in the complement cascade with elevated C4A through activation of classical and mannose binding lectin pathways. This triggers an amplified release of downstream signaling proteins. C4A protease enzyme can also be auto-activated, resulting in marked elevation of C4A. This results in what's described as a sicker-quicker phenomenon in some people upon re-exposure. And C4A is typically the first marker to rise after re-exposure. MMP9, or matrix metalloproteinase 9, is released by upregulation of the innate immune system and results in increased vascular permeability, permitting increased passage of inflammatory compounds into tissues. It typically rises 3 days after re-exposure. Leptin resistance is frequently seen in SIRS. Leptin resistance in the hypothalamus results in a low MSH and decreased endorphin levels, decreasing the pain threshold in people and resulting in more pain issues with SIRS. ACTH production is decreased as a result of hypothalamic leptin resistance as well, and this results in ACTH cortisol dysregulation. MARCONS. I think this is pretty much done in all SIRS patients. MARCON stands for multiple antibiotic coagulase negative staph. Multiple antibiotic resistant coagulase negative staph. Resistant is the important word there. And it's not MRSA. A lot of patients think they've got MRSA and it's not coagulase staph, positive staph. MARCONS can colonize the mucous membranes with minimal difficulty as a result of the MSH deficiency. MSH is important for mucosal immune health, and this then becomes a feed-forward disorder because MARCONS secretes exotoxins which split the MSH molecules apart, further reducing levels of MSH, and this enhances the ability of MARCONS to thrive. MARCONS also secretes hemolysins, which increases inflammation, and MARCONS has also been shown to alter the host genomic expression, and it evades host defenses with biofilm formation in the mucous membranes. ADH release is controlled by MSH, and 60% of SIRS patients have dysregulation of ADH osmolality levels, resulting in increased concentration of tissue fluids. They're not able to conserve fluid, and they have increased electrical shocks as a result of salt on their skin. This can cause the headaches I mentioned, results in excessive thirst, having to pee all the time. They just sort of feel like they've got a one-way stream going through their body sometimes, and they feel dehydrated all the time, even though they're drinking fluids. Androgen production is downregulated in about 40 to 50% of SIRS patients, and if the IP deficient, then estradiol levels may be elevated due to increased aromatase production. And this decreased androgen and increased estradiol is not appreciated in my male SIRS patients. VIP. This is the last step in the treatment pyramid. It is a neuroregulatory peptide that regulates the immune response and is produced in the hypothalamus and is frequently diminished. Transcriptomics has demonstrated the significant role VIP plays in SIRS. Transcriptomics has shown that measurement of VIP receptor 2 can determine if VIP is deficient or not, and VIP receptor 2 is intimately tied to the activities of a family of nuclear transcription factors called Icaros that I believe will be discussed in more detail later on in this conference. VIP deficiency can lead to dyspnea and pulmonary hypertension. VIP administration can reverse these symptoms and also downregulate the cytokines that I mentioned were elevated. Dr. Bryan here and his team have shown that intranasal use of VIP in SIRS patients, partway through their treatment protocols, modulated expression of both nuclear-encoded mitochondrial and ribosomal genes. Patients naive to treatment had profound suppression of those same genes. This demonstrates the benefit of using VIP to change the genomic expression of SIRS. Transcriptomics. This is the most sophisticated genomic testing available today. Molecular methods, especially transcriptomics, are replacing proteomics in assessment of causation of patient illness. Genomics is the source of all the confusing complexities of symptoms and groupings that we call clusters in SIRS. Here is the basis for SIRS illness. In addition, specific molecular patterns of gene activation and clusters of differentiation are seen with specific exposures. The most impactful modulator of cellular activity is differential gene activation, since the amount of the gene expressed is ultimately in control of the protein levels and the cellular output. Addition of transcriptomics to SIRS management demonstrates a molecular basis for the final pathway suggested already by the commonality of symptoms from various causes of SIRS, and in many ways has tied all of this together. It is documented that microbial toxins attack protein production at the level of the ribosome and energy production in the mitochondria. This can be demonstrated and followed with transcriptomics. Transcriptomics has shown the role of mycotoxin in causation of SIRS is at best trivial. Studies have shown that for every spore found, over 500 fragments of amplified molds, bacteria, actinomycetes, and mycobacterium are present. It is not just about mold. Transcriptomics provides precision in diagnosis, treatment, and tracking the progress in SIRS patients, and is the future of SIRS management. Thank you.
Well done.